Hey everybody, what's going on? Welcome to the hand and wrist of the leg, and by that I mean your ankle and your foot. Yeah, no, that was lame, but you'll see the similarities. So essentially, when we're looking at the ankle and the foot, what it's going to be comprised of is about 26 bones, just like the hand and the foot, or just like the hand and the wrist. You're going to have a bunch of smaller bones that are going to be used for support, and then some are going to be used for movement. You're going to have both intrinsic and extrinsic muscles. So we're going to have muscles that originate and terminate inside of the foot itself, just like we had muscles that originate and terminate inside of the hand. We're going to have a ton of ligaments. There's going to be a lot of ligamentous support. And we're going to have quite a few large muscle groups that are going to actually be spanning all the way down the ankle and into the foot. So those extrinsic muscles are also going to be there, and they're going to be quite large. Now, if we think about why the foot is so special, just like when we were talking about the knee, we have to support the weight of the body on the tibia. We have to support the weight of our body onto our feet. And really one of the first ways that we're going to be demonstrating how we have to support weight is going to be in walking, right? So the difference between walking and running, I don't know why I'm saying walking. I don't know. I'm going to struggle saying walking now for the rest of the day. I apologize. Regardless, the difference between walking and running is that with walking, you actually have a period of double stance. And what I mean by that is you actually have a point when both feet are on the ground. So you can see both feet are on the ground. Both feet are on the ground. You just are kind of like in this landing phase. But then you also have another period of both feet on the ground. So that is called a period of double stance. Now with running, you never have that period of double stance. You never have both legs on the ground. You only ever have one at a time, and you also have a period of time that is no support. So you have a period of time where you are airborne and you are floating, right? If you're faster, it might be longer. If you're slower, it might be slower. Regardless, however you cut it, however you chalk it up, we're going to have a period of time where we have to be supporting our weight on either one or both feet. When it comes to the stance phase, right? So that stance phase is going to be over here on the left-hand side, and it's about 60%, right? It's the majority of walking is actually going to be a period of stance. And that's largely because of that double stance phase, but it is going to be stance phased. And what's happening as you're walking, and I want you guys to go ahead and stand up, and as you're listening to this, try walking around in place and feel what is happening. The first thing that's going to be happening is you're going to have heel strike. And you're actually going to have your heel hit the ground. So as you look here on the left-hand side, you can see that there's a period of heel strike on that right leg. When that heel strikes, you begin to transition into a mid stance, which is where the foot has become all the way down. The foot's flat onto the ground. And then you actually take and you rotate that into a toe off, right? So essentially, imagine that this is my foot. Our foot's coming down, we're hitting on our heel, we're rolling our ankle forward, and then we're rolling our ankle forward. So we're actually going to be heel strike, flat, toe off. Heel strike, mid stance, toe off. Heel strike, mid stance, toe off. As you're going through this, and as you're practicing this in your own house, as you're walking to class, whatever, I want you to be paying attention specifically to what your foot is doing. How is your foot actually rolling as we're moving on, as we're hitting a heel strike and then rolling into that mid stance and into toe off? Realistically, what you should be doing, as long as you're not painfully flat-footed or you don't have really messed up plantar and dorsiflexion, you should be supinated. Your foot should be supinated when you hit. So you should actually roll from your heel down the outside of your foot onto the ball of your foot and then back up. So it should be a rolling motion. So that you are actually heel strike supination, rolling into pronation, and then toeing off and returning back into a supinated position. So do it, right? Hit pause and try it out. Did you see what I was talking about? Did you feel how your foot was actually rolling? So a good way, something that you can do on your own, especially if you're into running, some of our cross-country athletes or really any of our athletes or fitness people in general, this is why you look at the bottom of shoes to look at wear patterns. This is why you are actually analyzing shoe patterns of patients. This is why when you're working with elderly patients, you can actually see that they have an uneven wear pattern on their shoe or a non-normal wear pattern because they actually have a shuffling-based gait. So you can tell a lot about an individual's kind of mobility abilities based on the way that they have a wear pattern, because it should be a reliable supination to pronation to toe off. It's not always going to be that way though. Now the other portion of walking is going to actually be that swing phase. So all that we're doing, we've already toed off and we're swinging the leg through. So that foot leaves the ground, we move that foot forward, back for another heel strike. So that's the other major portion of walking. So we have a stance phase, period of double support, single support, and we have a swing phase, which is where that leg is actually coming through and preparing for another heel strike. Just like we had in the hand, we're going to have how many phalanx are going to be present in our thumb or in our big toe or in our first metatarsal, right? 2. Whereas our other fingers or our other toes are actually going to have 3 phalanx. So it's going to be very, very similarly set up to the hand or to the wrist. So we're going to flip back and forth here, and I apologize for having to do that. I couldn't fit all this onto one slide cleanly. What I want you to see is that when we flip back to the foot position, you can see that we have a talus bone and we have a calcaneus. So this is actually going to be our inferior view, and this is going to be our superior view. So our tib fib is actually going to be coming in right here, right? This is a superior view. We're actually looking down. And this is our inferior view. So we're looking up at the foot. So our tib fib is actually going to be coming in here. And we're going to have a medial and a lateral malleolus as we're bringing the tib fib in right here. Almost all of the weight is going to be run through to the foot by the talus bone, which is going to be right here, and our calcaneus bone, which is going to be found right here, right? So the two major bones that we're going to be transferring weight through are going to be our talus and our calcaneus. So we're going to have 5 other kind of rear and midfoot bones, if you will. If you go over here, we're going to have a navicular and we're going to have a cuboid. So you can see that we're going to have the navicular bone up here, which would be here, and we're also going to have the cuboid bone, which is going to be on the lateral side. We're also going to have 3 cuneiform bones. They're not Egyptian as far as I know. But you're going to have the lateral, medial, and intermediate cuneiform bones. So these are going to be immediately attached, or these are going to be just proximal to the first, second, and third metatarsal. Whereas that cuboid bone is going to be just proximal to that 4th and 5th metatarsal bone. Again, just like we had with the hand and with the wrist, we're going to have 3 phalanx in our primary fingers or our primary toes. And then in that first metatarsophalangeal joint, we're only going to have 2 phalanx. So in that first toe, or in your great toe and your big toe, you're actually only going to have 2 phalanx. You're going to have a distal and a proximal phalanx. Whereas the others are going to have a proximal, a medial, and a distal, or a proximal, a middle, and a distal phalanx present. Since we're talking about the ankle, we also need to be talking about the tib fib, or the tibia and the fibula, and how they kind of play a role here. So essentially, what we're going to have is we're going to have the tibia and the fibula essentially being placed down on top of the talus and the calcaneus. And when they do, we're going to be producing a pulley system. And I've got another picture to demonstrate what I'm talking about for you guys on that. So when we're talking about the ankle, we need to be also considering the tibia and the fibula, right? So we need to be considering the bones that are just proximal to the foot, because they're going to be providing the proximal attachment sites for some of these muscles that are extrinsic, and they're also going to serve as an articulation face. When the tibia and the fibula come down on top of the talus and the calcaneus, we're going to have 2 malleoli. We're going to have a medial malleoli and a lateral malleoli. They've got a kind of goofy name, but they've got a really cool function. Essentially what they're going to do is they're going to serve as pulleys. So they're actually going to allow for muscles to wrap around the back of the malleoli and produce a greater mechanical advantage, or have a greater mechanical advantage, and thus they can actually exert a greater effect. And I'll show you what I mean on the next slide. This is going to be where we really are really able to see this pulley action in occurring, if you will. So we're going to have our Fibularis Brevis and our Fibularis Longus. You can see this Peroneus Brevis, Peroneus Longus. I'll try my best to be consistent, but they really do flip back and forth. And so as you can see, this Fibularis Brevis and Longus both have an origin on the lateral posterior side of the fibula, the proximal lateral medial, or proximal lateral posterior side of the fibula. It's a lot. But if you look down, as they're tracking all the way down the fibula and towards their insertion, you can actually see that they wrap behind that lateral malleolus. And by wrapping behind that lateral malleolus and then inserting on the base of that fifth metatarsal and all the way on the base of that first metatarsal, we're actually able to create a greater mechanical advantage for turning that ankle. So actually moving into plantar flexion and actually getting a better joint angle and angle of pull because of that. The muscles that are going to be immediately behind the medial malleolus, you can refer to as the Tom, Dick, and Harry. Most of you guys are way too young to know Tom, Dick, and Harry, but it's our posterior tibialis, or tibialis posterior, flexor digitorum longus, and our flexor hallucis longus. So that means we're dealing with our flexion of the toes and flexion of the great toe, or flexion of the big toe. So if you go back to the knee joint, and when we were talking about the knee joint, we kind of talked a little bit about the tib fib and how the tibiofibular joint, some people refer to as a part of, or some people refer to the fibula as a part of the knee, and it's not really. Again, here, essentially what the tib fib is going to be doing is providing additional attachment sites, both origins and insertions for muscles. They're going to realistically, the tib and the fib are going to be joined so that there's very minimal movement. There's not a ton of movement that's actually allowed between this joint. But what it does do is it provides us a really good, strong joint structure. And it allows us to basically create what is really a good hinge-based joint. And that hinge is going to be comprised of the talus bone. Remember, we're transferring the weight through the talus and the calcaneus. It's going to be comprised of the talus, the distal tibia, and the distal fibula. So on the medial side, it's going to be the tibia. On the lateral side, it's going to be the fibula. And then that weight's going to be coming in on top of the talus bone. It's going to allow for approximately 50 degrees of plantar flexion, 15 to 20 degrees of dorsiflexion. We'll go over what those are, don't worry. And you're going to have improved ranges of motion based on knee flexion or extension levels. We're also going to have some rotation abilities that are going to occur, but it's really, really, really minimal, right? Like 3 to 5 degrees, really small amounts of movement. So something that I always struggled with was, why is it called plantar flexion and dorsiflexion? So dorsiflexion is when we're actually coming more in like a true flexion. So you're actually coming and bringing the foot closer to the shin bone, right? So if you were doing a squat, you'd be going into dorsiflexion. If you try to push your knees over your toes, you're going into dorsiflexion. And the reason that it's actually called dorsiflexion is because it's dorsal flexion. Now, if you remember anatomical terms and directionality, dorsal usually means back side of things. And the problem is that anatomy terminology does not just apply to human anatomy. It applies to all types of animals and all vertebrates. So if you were to actually put someone on their hands and feet and you were to have them be situated like a dog, so their hands are on the ground and their feet are on the ground, then that top side of the foot would actually be the dorsal side. Just like a dorsal fin is on the back of a shark, you would have the top side of your foot would be the dorsal side. So it's actually a flexion towards the dorsal side. Kind of cool, right? If that's dorsiflexion, then plantar flexion is when we're what you would actually think would be extension, but it's actually a true flexion at the same time. So this hinge type action associated with the ankle joint, this flexion extension or this dorsiflexion and plantar flexion, is going to be occurring in what plane? The sagittal, right? So when it comes to inversion and eversion, we're going to be dealing with frontal plane movement. So sagittal plane movement, dorsiflexion, plantar flexion. Frontal plane movement, eversion, inversion. So inversion is actually going to be frontal plane movement, rolling that foot in so that the sole of the foot is moving medial. Eversion is going to be actually rolling the foot to the opposite side. So it's actually going to be rolling the foot towards the outer side of the foot. Realistically, there's still not a ton of motion associated with this. You can have some levels of inversion and some levels of eversion. Most people, it's not a whole bunch of eversion. Continuing on with the joints, and just like we had in the hands, we're going to have, rather than metacarpophalangeal MCP joints, we're going to have MTP or metatarsophalangeal joints. And this is going to be where those phalanges actually reach the metatarsals. And with that MTP or the metatarsophalangeal joint, we're going to have both flexion and extension, and we're going to have adduction and abduction that occurs somewhat, right? Like, have you ever seen someone that's able to like spread their toes? One, it's basically a circus trick because I can't do it. Two, it's still possible. So just like you had with the hand, anything moving away from that center ray is going to be abduction. Moving towards that center ray is going to be adduction. So you can actually have digits moving in opposite directions and both be abducting, or digits moving in the same, like different directions and both be adducting. We also have those interphalangeal joints. So we're actually able to individually manipulate those interphalangeal joints so that we can move the proximal, middle, and distal phalange different levels. So that proximal interphalangeal joint is going to be capable of about 30 degrees of flexion. The distal interphalangeal joint is going to be associated with both extension and flexion, and then the interphalangeal joint of the great toe is actually able to go 90 degrees, right? So we're actually able to go 90 degrees into flexion, which is kind of a weird looking thing. I don't know. You guys would learn that I have no flexibility or mobility whatsoever. Just like it was really relatively impossible to talk about the knee without talking about ACL, PCL, MCL sprains and tears and stuff like that, it's really difficult to talk about the ankle and not talk about ankle sprains. So realistically, a sprain is a tearing or a stretching of one or more ligaments. A strain has to do with muscles, sprain has to do with ligaments. So here we're essentially taking our joint through too far of a range of motion, and we're actually excessively stretching that ligament. So the ligament's how we attach what? Bone to bone, right? Tendons attach muscle to bone, ligaments attach bone to bone. So this is a way that we can, essentially what a sprain is it's where we have excessive movement associated with the joint, and we put excessive force onto that ligament, and we might stretch it, or we might pop it or tear it or rupture it, however you want to refer to it. Most ankle sprains are going to be related to too much inversion. And when you invert too much, that means that the lateral ligamentous structures are going to actually be affected. So if we take and we roll our ankle inwards, like rolling your ankle in basketball or rolling your ankle in sport, almost always are you going to roll your ankle in. So that means you're almost always going to have sprains on the lateral side of your ankle. It is possible, however, to have medial ankle sprains. They're usually due to like a contact-based blow. So if you're going into a tackle in soccer and someone hits the ball right at the same time you do, you might actually evert quite a bit and strain those medial ligaments, but it doesn't happen as often. So if someone talks about rolling their ankle or spraining their ankle, it's usually going to be that lateral side. I want you to take a second and just look down at your feet. I know that's a weird thing to ask, but seriously, just take a second and look down at your feet. What are you going to notice that's different than your hand? While your foot's basically a hand of the leg, what's different? We have arches, right? And not only do we have one arch that runs from like the long way of our arch, but we actually have an arch that runs the medial way. So we actually have an arch that lifts and supports basically lifts up the bones in our foot away from the ground in the middle of the foot, both the lengthwise and the widthwise of the foot. The transverse arch is really going to be due to the structure of those metatarsals. When you look at those metatarsals, they're actually kind of rounded down. So they start at the talus and calcaneus, and they kind of round up and then round down, right? They already have an arch-based structure. They already look like McDonald's down there. Now, the longitudinal arch is actually going to be split into two. So we're going to have a medial and a lateral longitudinal arch. And you can't really see the medial. You can see the longitudinal arch running down in this picture right here. But essentially what the longitudinal arches are going to be doing is pulling the foot up, so that we're actually going to be creating that kind of arched structure of the foot, if you will. So what you can see is that transverse arch and that ligamentous support is really going to be pulling on those cuneiform bones, as well as that navicular bone and that cuboid bone. So we're really going to be pulling up on those bones right as we're going into those metatarsals. We've already talked about these, but I want to show you a demonstration of what the pictures look like, or what the movements actually look like. So dorsiflexion, remember, this is still a flexion. We're decreasing the joint angle, but we're doing so by pulling backwards, or we're pulling the toes towards the shin bone. And then plantar flexion is we're actually taking and pushing the toes further. So we're actually extending or pointing the toes. Standing on our toes is plantar flexing. Eversion is that rolling out of the ankle and occurring in the frontal plane. And then inversion is rolling in of that ankle and moving in the frontal plane, so that we're actually putting more weight on the outer side of the foot, on the lateral edge of the foot. So what creates pronation and supination, I was hoping that would be perfect. So what's going to be creating pronation and supination is actually, rather than being a two-dimensional movement, right? So rather than just being sagittal plane or just being frontal plane, it's actually going to be a three-dimensional movement. It's going to be a combination of dorsiflexion, plantar flexion, and eversion, inversion. We can have toe flexion and toe extension. You guys should already know this. But now let's talk pronation and supination. So you can see that on pronation, it's actually a combination of ankle dorsiflexion. So we're leaning the tibia forward, or we're bringing the toes up closer to the shin, and we're everting the foot. So we're actually rolling to the inside of the foot as we're dorsiflexing. This is what, if you're looking at an individual with low arches or with flat feet, this tends to be how they walk. So they're actually in an overpronated state. Supination is a combination of plantar flexion, so toes down behavior, and inversion with forefoot adduction. Basically, what you're doing on supination is you're rolling along the outside of the foot. So you're actually rolling around the outside of that arch. So when you have normal gait, you're actually combining supination with pronation. So we're rolling along the outside of the foot and then rolling onto the midfoot. Rolling around the outside of the foot and onto the midfoot. That's how a normal gait cycle should be occurring. We get to investigate muscles in this really cool surgery next.